I had a very warm welcome. I have never been in Romania and Bucharest. I have been quite around the world for some time. My background in short is that I have education in pathology, internal medicine, radiation diagnostic, and radiation therapy. My training places were the University of Erlangen, University of Würzburg, Hahnemann, University of Philadelphia for 2 years, and at the age of about 39, I became chairman in Essen, and since 3 years I'm working at the Hamburg Strahlenzentrum, and it was a great risk but also a challenge to be the first Cyberknife center in a private radiation therapy facility in Germany. So even for us, radiation therapy and Cyberknife is an adventure. So a warm welcome, and as you see with clouds, we are not sure if the sun comes out or rain will fall, but rain is the seed for plants to grow, and this is just a cloud, very much the shape of Romania. So it resembles this country and it resembles the hopes I have for you and la multi-anni for this endeavor. So we are back to Hamburg, and from that we start with some thoughts and perspectives, and I want to introduce you into the background of implementing Cyberknife in radiation therapy. First of all, some general considerations. Germany is a more developed country, and in a population of 80 million, we expect about 400,000 new cancer patients per year. If you see the indications, 2/3 of all patients which are diagnosed with cancer will have to receive radiotherapy in their treatment in the disease course. About 50% for cure, we call that curative treatment, and another half for palliative treatment. We can't cure the disease, but we can help the patients to get rid of their symptoms, of reduction in quality of life. One of the successes in oncology in modern times is the interdisciplinary approach. So the disciplines are not governed by one who is the tallest in size or the most beds or the most money. It's the best knowledge of joining all disciplines together. So it is sometimes changing the sequence of therapy. Surgery is second, and chemo or radiotherapy may be first. Major successes have been achieved with varying combinations and varying sequences of the treatment. So it's important that all the specialists join together in specific boards, that they create a network of knowledge, and that they join and organize themselves in cancer centers. The principle of cancer centers is not, again, majority experience. It's the best knowledge for the individual case to be treated. In addition, we have experienced great successes in technical developments. We can diagnose cancers from pathology by specific imaging methods, using specific components to make cell components more visible. We can use in surgery robotic techniques. Visualization has been increased. You see advertisement from PET-CT, but the same has been in radiation therapy. We had major technological and methodological advances in the future. Now, transferring the situation to Romania, it means that you have about 1/4 of the inhabitants of Germany, and if you become a developed European country and you are on this step already, you should focus and make up a program. What should be the focus of the next 10 years? And from that on, you can expect about 100,000 new cancer patients a year. If you consider that about 1,000 are usually treated in a radiation therapy facility in Germany, you could expect about 100 developed radiation therapy facilities in your country if you distribute them well in the population. Again, in your country, you will have the same situation to give them treatment for cure or for palliative reasons. And again, you should try to implement interdisciplinary concepts and create partnership between all the disciplines. One of the points today is that we be partner of your conference and we share experience which is a teaching experience which I myself experienced when I came to the States. I was learning, and by learning I also helped teachers to create the right message. It's not that teachers overpose disciples and disciples are only inferior. The disciples are so quick in learning that they always overcome the teachers, and that should be the goal. You have so much input and you have new problems which we haven't seen, but we can learn from your problems. And we become together a very new approach. So joining information is always sharing and learning on both sides. It's also important that you share quality management. You should have clear procedures, not in one institution, but in all institutions who do cancer treatment. And that is written down in terms of guidelines, and you yourself can inform from the international guidelines, but you may create specific guidelines for Romania and for institutions. But in the long run, you have to measure your results and compare them with results on the international level. And certainly you are interested in the implementation of new techniques. So one of these advances, and I want to go with you step by step through the advances we have seen in Germany and which you will also experience in your country. The major step is that we move in radiation therapy from 2D planning, where we have a volume, let's say, by 10 by 10 centimeters, or a voxel of 10 by 10 by 10 centimeters, usually 10-15 years from today. We were planning just the central plane. We made a circus around this body, and we looked for the central plane being representative of all planes in the volume we were treating. This has been overcome by using computers and using many planes. In a 10 centimeter level, if you make 5 millimeter layers, you create 20 planes. And all over those 20 planes, you calculate the full volume. So this is the progress from 2D to 3D planning. And from this full set planning, we create the dose exposure to each individual organ and create curves by which we can see what is the risk for which organ in this volume to be exposed to a certain dose. And by that we can implement the risks for these organs, and we can improve plans by saying we are not just using two fields opposing, creating the full set of dosage to all organs in between, but we can create 3, 4, 5, 6 field plans. And secondly, tumors are not cubes. They are not round bowls. They have irregular shapes. If you fly around Frankfurt, or you choose a modern city with skyscrapers, the perspectives of the city changes when you fly around it. But your tumor is just part of the city. You have an evil building. I say with the bank crisis, look at the German bank in Frankfurt. And when you fly around Frankfurt, you always target, you want to get this building being just shut down. So you're shooting on that, but you protect all the other buildings. If you make a 180 or 36 degree circle, this building will fall apart and you have no, what we say, damage in the surrounding, or collateral damage, which is called in military. We have a similar approach in radiation therapy. We want to avoid collateral damage in the vicinity of the tumor. And this is being done by using the shape of the tumor with the risk area and using these perspectives from all angles around the body. And this can be done by so-called multi-leaf collimators. The shape of the tumors is set up in little leaves which can be brought into the field or can be pulled out of the leaf. And if these movements can be done very quickly in a circle around the patient, then we have a flying, changing layer situation where the shape of the field adapts to the perspective on these tumors. And this is done with multi-leaf collimators, and we create then intensity modulated radiotherapy. Another advantage is that we can use nowadays LINAC accelerators to create CT images. So we create these layers from which we are using for planning. And on the machine, you create this layering imaging, compare it with the initial planning, and then move your target exactly into the center point where all the planning has started. By doing this, we shorten the whole planning process by more than 3 or 4 days. This is what we call virtual simulation. So we have now conquered the 3D space. But what about our bodies? We are shaking, we are breathing, we can have Parkinson, all other sorts, or we can have the bowel movement in our body. So the whole system shakes, trembles, moves. And with that, we need 4D planning, accounting for the movements. For example, many tumors are in the lung, but the lung is moving, so the tumor is moving. This is being done by looking into all movement and then integrating all movements in a planning process. And then we call it not the target volume, but the integrated target volume, which is usually much larger than the actual tumor volume itself. And not creating a too large volume gives us the solution to fix the tumor into a certain position or only irradiate the tumor in a certain position. The best would be inspiration, because the ratio between lung and the lung tumor would be the best. But this is not always possible in patients having additional disease. So this is one aspect dealing with fixed geometry radiotherapy. But you could move the table, you could move the patient, and by that you would create radiation beams not just perpendicular in a 90-degree angle to the body. And we call these techniques, instead of coplanar, which means 90-degree angle radiotherapy, we call it non-coplanar radiotherapy. I will show you some of them. Unless it's just for the pleasure of the healthy people, treating sick people. So it's a question if 5 times 2 gray is really a very good solution. It's an evidenced solution, but it's not really probably the best. There are tumors very rapidly growing, so that they may be treated better with 2 times a day. There may be other tumors very slowly growing, and they may be best treated with, let's say, 3 treatments per week. We have not optimized the biology and the temporal aspect of radiotherapy, and this will be probably the 7th or 8th dimension of radiotherapy. We will learn this. Chemotherapy, by the way, is exactly doing this. They are using the chronological treatment. They are using the best approach, and they have learned from radiotherapy that chemotherapy is probably not given like a tsunami, one shot and it shakes the whole body with the poison. It's the very dripping chemotherapy in a very low dose, which is not being toxic for organs, but is helping in a very long run to be adding to radiotherapy. And radiotherapy and chemotherapy are exactly working like that. It's a continuous flowing chemotherapy, which is probably better in conjunction with radiotherapy than the high dose type of chemotherapy drugs. And that means that for the individual tumors, we have to look for very individual solutions. So this is the program slide. Next slide is what very solutions we have. Perpendicular approach into the body. And this has to be fixed to be very exact. So we are going with the source which weighs something like 2 tons in a very precise manner about the body. And this is what I showed you and I explained to you before, the multi-leaf collimator. The multi-leaf collimator can change the shapes depending on the perspective onto the tumor. And Cyberknife tools all work with the fixed geometry principle. The machine comes to the human and adapts to the position. That's the major principle between Cyberknife and all other for the arc therapy at the linear accelerator. Patients are fixed 30 to 40 minutes in these systems. Or here you see the compression stamp and the situation for the patient being treated on the accelerators for radiotherapy or stereotactic body radiotherapy. And this is the answer from Cyberknife. And here you see the different system components. You have a linear accelerator, which is mounted on a robot. And this robot is so precise that we produce millions of cars with that robot. It's from KUKA, and it's in all Mercedes, BMW, or any other auto or car manufacturer fabrication sites. It is so precise that it can mount a little piece of 5 grams from A to B with 1 millimeter precision. Compact linear accelerator, it will act the same. Here you see the X-ray tracking, the optics. And here it gives you a display of what are the actual projection points you can create. And a matter of fact, it's not a projection just through the equatorial line, it's a projection from the North Pole to South Africa. All these projections. By that, you have 1,600 projections. And within this projection, the beam can even tilt and make additional movements. And this creates a unique conformity around the tumor to be irradiated throughout the body. Gamma knife is just for the upper part of the head, limited, while Cyberknife can be moved throughout the body as a flexible tool. Gamma knife can't adapt to movements, Cyberknife can. And so in terms of position control, we have the control of the tumor, we have the control of the patient, but sometimes we can't read this tumor. The tumor is not as opaque in the cage of the lung. So it's not the penetration by the X-rays, so it can't be read. Where is it from the X-ray? So we have to give some help. The prisoner in the cage is not detected behind the iron bars. So we put on the prisoner a metal watch. Yeah? We give him a metal decoder in his pocket, and we put some metal detectors in his shoes. What I want to say, by that we can detect where is the prisoner behind the cage. And what we are doing with the tumor, we are placing fiducial markers, gold metal markers, around the tumor or in the tumor. And if these fiducial markers are moving with the tumors, we can again read the movements of the tumor. So Cyberknife in moving targets is often associated by placing metal fiducial markers in the vicinity of the tumor or in the tumor itself. And so I show you this type. You can do all sorts of radiological procedures, biopsies, or even therapy via CT tracking. And that's exactly the same approach, placing fiducial markers around or in the tumor. CT technology. And this is just to mark a lung tumor right here. So it's conventional knowledge of an interventional radiologist. So you need to have a radiologist as a partner. And then you have these fiducial placed, and by having these fiducials placed, your rim and safety margin becomes considerably smaller than in all other radiation therapy techniques. On the left side, you can see the possible movements. It's a large movement, and usually you would have to treat all this volume, but with Cyberknife, you just treat the small volume around the tumor itself. And then you watch the patient with a special jacket. There's a jacket and has these little fiducial markers which are detected by the optical system. And then the beam can walk with the target in the lung. The whole movable target precision is in the range of 1 millimeter. So that means we can give a margin, let's say 3 millimeter around it. We can still consider there are maybe some infiltrating fingers in the lung tissue, so it's always a resolution question of the resolution of the CT we create from the lung. And so one of condition to plan these tumors is the 1 millimeter layering of the CT, which is the basis for treatment planning. And the same if we are dealing with brain tumors for the MRI. So you have a high resolution CT and a high resolution MRI, or even high resolution PET, to use that for planning, and we call it the stereotactic imaging techniques. Radiobiology. It's very unusual to give in one shot the whole radiation dose because we are so much afraid as radiation therapists. So I'm stepping to that side. But as a surgeon, we have to kill the tumor and have to step to this side. So, do we have any experience with these high doses? Yes, we already have. With brachytherapy, where we place radioactive sources into a tumor, and this has been done for 80 years, for 100 years. And we have learned that with brachytherapy, we cure patients. So we shouldn't be afraid. We just have to create these very confined dose volumes around our tumors, not by means of putting a radioactive source in it, but creating it from the outside. So giving boost treatment, giving brachytherapy treatment shortens treatment, makes it considerably more effective, but is also a very high requirement for geometry. Tissue reacts differently. If you damage normal tissue, it can be destructive and you lose organ function. So in terms of tissue, you want to give always little doses, so you want to fractionate. In terms of tumor, you don't want to fraction, you want to be very effective. So these are contradictory principles. Unless you give radiation to a very confined area. So hypofractionation and very precise radiotherapy meet each other's interest. And by having these tools available, all of a sudden, radiation therapists reconsider to do hypofractionation. And that is a new area in radiobiology, study hypofractionated effects. And you see tumor different. And what we need to achieve is doses beyond 100 gray. If you would give 100 gray, we would probably need 10 weeks, 2 gray, and we would create a terrible pneumonitis, so inflammation around the treated volume. Because even with very low doses around the tumor, treating them every day will destroy physiological function in surviving lung cells. It's most interesting that we only give 2 or 3 fractions of radiosurgery. Usually we don't see pneumonitis because the surrounding normal tissue doesn't accumulate low doses, which makes physiological changes. And this has been shown now in a plot to go surgery or have some sort of restrictions otherwise. So if Cyberknife can be adapted to a very old patient, it could be also adapted to a somehow compromised younger patient. I'm going to some examples. Here you see imaging with PET. PET-CT certainly helps us to read these lesions in the lung better. Certainly you need histology. I wouldn't treat a case just with some CT show up like that without histology, because one of the problems of the lung surgeon is the granulomas.